that's being proposed for Mauna Kea on the Big Island of Hawaii. We as settlers must work toward a world where we're organizing to make institutions like CSUN accountable to the needs of Indigenous students and their communities, including the Tataviam. And we are working, and envisioning a world where we can, move in solidarity to return the land to its stewards. Second, some thank yous are in order. On the behalf of CDSC, I wanted to thank the members of the audience who are Zooming into our webinar today. I wanted to thank the Office of the Provost, whose support has been instrumental in CDSC's programming. I want to thank the Deans of the Colleges of Humanities and the Mike Kerb College of Arts, Media, and Communications, Jackie Stalcup and Dan Hoskin. Deepest thanks to our wonderful and talented CDSC interns, Vivian Lay, Janessa Reyes, and Mary Chavez, as well as our administrative support staff, including Erica Barone of the Communications Department and Filia Militante of the University Corporation. Today's program is funded through the California Civil Liberties Public Education Grant. The Civil Liberties Grant is a program of the California Library, whose goal is to increase public awareness about the forced removal and incarceration of West Coast Japanese migrants and of Japanese Americans during World War II, and to focus more broadly on civil rights and civil liberties violations due to race, ethnicity, religion, gender, sexuality, and migration status. In short, this grant helps us envision how access to healthcare, particularly for the most vulnerable communities, is a right. When we originally conceived our grant, that was prior to the global pandemic, so we did not originally have programming geared toward this crucial topic. In organizing this event today, we wanted to be able to address the pandemic's effects on communities that are or have been made structurally vulnerable to economic downturn, to housing and food insecurity, to lack of adequate and affordable healthcare, to lack of comprehensive and compassionate elder care. Communities like the multiracial, working class, and largely migrant residents of Los Angeles' Chinatown area, who include not just Chinese Americans, but also Southeast Asian refugees from Vietnam, Laos, and Cambodia, and Latinx residents. Communities like Pacific Islanders from Samoa, Guam, Hawaii, or the Marshall Islands, whose vulnerability to COVID has been exacerbated by the ongoing effects of settler colonialism, and who we know so little about as members of these communities are routinely ignored by state institutions, including CSUN. We hope that today's program will help us think through the question of structural inequality and its effects on communities who face multiple overlapping vulnerabilities, as the geographer Wilson Gilmore will put it, to premature death. And now I'd like to introduce my colleague, Professor Marta Lopez Garza, who will introduce our two speakers today. Professor Lopez Garza is a professor of gender and women's studies and of Chicano studies, and most importantly, is one of the co-founders of Civil Discourse and Social Change. Please welcome Professor Lopez Garza.
Thank you, Clem, for that amazing introduction. And I have the honor of introducing our two guest speakers. Corina Pedaya is the Community Engagement and Research Director and co-founding member of the Native Hawaiian and Pacific Islander Data Policy Lab at the UCLA Center for the Health Policy Research, CHPR. Prior to joining the UCLA CHPR, Penaya served as a program manager for a nonprofit organization, the Asian Pacific Islander Forward Movement, where she worked closely with policymakers and community stakeholders to address prevalent health issues that impact Pacific Islander and Asian families. Her experience includes implementing public health programs in underserved communities. Penaya has a passion and extensive expertise in producing culturally relevant and sensitive programming around food insecurity, chronic diseases, and related policy and advocacy, and implementing nutrition education and obesity prevention programs. Penaya holds a bachelor's degree in biology from Pitzer College, a master's degree in public health from California State University, Fullerton, and is currently a PhD student in health policy and management at UCLA. Welcome. Dr. Felix Aguilar is the Chief Medical Officer of Chinatown Service, where he leads the improvement and redesigning of clinical care by implementing patient-centered medical home principles. Dr. Aguilar's key accomplishments include the beginning, I shall wait till he is centered on the, there we go. At the beginning of the COVID pandemic, he led the rapid conversion of 80% of CSC acute in-person visits to telehealth in just weeks to increase access to patients. He also improved timely access to hospital records in the Los Angeles County hospitals by 75%. Previously, Dr. Aguilar was medical director of Blue Shield of California, where he reduced the hospital readmission rates from 13 to 7% at his clinics in the Antelope Valley. During his career, he has performed extensive work in community health for the purpose of bringing together stakeholders to improve patients' health. Dr. Aguilar attained his medical degree at the University of California, Irvine. He also has completed a Master's of Healthcare Management at Harvard University and a Master's of Public Health at Tulane University in New Orleans. Dr. Aguilar trained in family medicine at UCLA and in preventative medicine and public health at the California Department of Health Services. Moreover, he is board certified in family medicine and a fellow of the American Academy of Family Practice. Both of our guests merged their medical careers with their progressive politics and their commitment to working in low-income neighborhoods and servicing people of color. We are pleased to welcome Ms. Corina Benaya and Dr. Felix Aguilar.
Welcome, everyone.
Dr.
It
Corina?
is-
Sorry.
Nice to be here. Thank you, everyone.
You can start. Corina Benaya.
All right. Talofalaba, everyone. Hello, and thank you sincerely for inviting me to join today's webinar. My name is Karina Panaya, and I will be sharing a little bit more about the NHPI Data Policy Lab, which is currently housed at the UCLA Center for Health Policy Research under the direction of Dr. Ninez Ponce. As always, if you do have questions, please feel free to throw them in the chat, or we can go ahead and answer them at a later time. I'm here to be a resource. And so working with community experts and acknowledging their diversity and background is very critical to our work. The Pacific Ocean is home to well over 20,000 indigenous islands, each known for their uniqueness, including their culture, lifestyle, languages, and traditions. Within the United States, there are over 1.4 million Native Hawaiians and Pacific Islanders, where about 20 NHPI subgroups are counted by the census based on self-reporting. And I also want to mention that this is nowhere near an exhaustive list, which falls under three main groups that are listed on the right side. So we can see Polynesia, Melanesia, and Micronesia. And so looking at the data in specific subgroups helps to inform advocates, health researchers, and government stakeholders on how COVID-19 impacts really affect NHPIs, and hopefully we can bridge the gap in needs and services for all. Devastatingly enough, Native Hawaiians and Pacific Islanders continue to experience some of the highest COVID-19 case and death rates. As indicated in these line graphs, we see that NHPIs, represented as the orange lines, have the highest COVID-19 case rates in comparison to any other racial and ethnic group across the country, including states like Arkansas, where most of our Marshallese community resides, and our other Pacifica families in Utah and Alaska. And so you may be wondering, well, why are the numbers so high? What's going on in this community? Just a few things to consider. About 25% of Native Hawaiians and Pacific Islanders work in essential roles, which can include but are not limited to military positions, health and service related industries, manufacturing jobs, and security, which only continues to further exacerbate their risk. There are also quite a few social determinants of health to consider, such as barriers to access, barriers to health services and care, income, and also thinking about discrimination in the workplace. Additionally, the case rate data for these trend lines have only been made available due to the states that currently report disaggregated data for NHPIs. In the 20 states that do report their case rates, NHPIs rank first in about 70% of them. And so we see that a lack of timely reporting of disaggregated data for NHPIs has curtailed funding and public health program efforts to shed light on the alarming impacts and address urgent health need in these communities. When it comes to community organizing around COVID-19, when the pandemic first began, I must say that community leaders and members quickly got to work, regardless of the resources that were allocated for them. And so different organizations, churches, school groups, you name it, were organizing together to address some of the most immediate needs in our community. And so, for example, the National Pacific Island COVID-19 response team convened a diverse group of professionals and community leaders to leverage resources and understand how NHPIs were being impacted by COVID-19. And so being a part of a space that was created uniquely just for us, where everyone was willing to pitch in and help was such a beautiful experience to be afforded. And I will always value that and continue to take that upon my journey, both in my education and professional journey. And so building relationship in the community with humility and mindfulness is something that we always try to hold on to when we are working in such unique spaces. From families losing very close loved ones due to the virus and still holding the responsibility to make ends meet and continue working through unsafe conditions, these were some of the common narratives that our folks shared with us, which informed a sense of urgency to create a data infrastructure that complemented such unfortunate realities. And so this ultimately led to the formation of the NHPI Data Policy Lab. And so this is just a visual of when we first put the Data Policy Lab together, which was created by and for the community. Presented on this slide is a breakdown of how the Data Policy Lab came into fruition. The lab was created at the request of NHPI community leaders who advocated for disaggregated data to elevate and better understand the disparities NHPIs continue to face throughout this pandemic. First, Dr. Ponce and Dr. Mori spent countless hours scraping and gathering data, and due to the growing demand and very little bandwidth of our team, NHPI scholars and students were selected to help with the data scraping, the collecting, and the analyses process. We were able to develop data summary reports for community use, and due to increased requests to cover more geographic regions, we transitioned from manually scraping and inputting data to automating the data process. Thus, our online COVID dashboard was born, which helps us to better visualize all of the data collection and analyses we conducted. And so I'll get into that a little bit later. I also want to mention that we did put our COVID-19 dashboard together, which is housed on the CHPR website, which I will share the link to later. And we do have a few projects in the pipeline that we're hopefully gonna send out to the community, which will provide more insights regarding how we can continue to democratize data, which data related topic areas we should continue looking into, and of course, learning how to make this more accessible for the community to utilize for their own purpose. And so with this in mind, whenever we're developing new tools or projects, we always welcome and value community input to ensure that the products we're creating are really in alignment with what they need. Okay, so the goal of our lab, which is to support community efforts in 4 key areas. Evidence and data truly matter when focusing on advocacy efforts, and it also justifies how, where, and why resources are allocated, all while capturing the attention of stakeholders who really make or break a positive impact. We know that data is essential to not only empower, but also educate our community with knowledge so that they can learn how to care for themselves and families when issues such as the pandemic take place. And lastly, we strive to democratize data and make it more accessible for our community. We believe that our members should be able to access our data and tell our story for ourselves. And by doing so, we hope to bridge existing gaps in health policy and improve health equity. All right, we're going to switch gears a little bit and talk about the process of scraping the data and how we were able to automate it. And so after several conversations with community experts, The community and the stakeholders were very clear in providing feedback to us to help determine which states and counties we should be prioritizing with our data collection regarding the COVID-19. From there, each of our team members were responsible for manually scraping the data on a weekly basis from state monitoring systems and also data dashboards from areas of interest. This proved to be a very labor-intensive process. However, thankfully, with the help of our automators, we were able to utilize Python scripts to automatically scrape COVID-19 data where possible. And of course, for best practice, all of the entries we inputted were reviewed for accuracy to mitigate any discrepancies and then organize them to create data products such as the weekly data reports and our online COVID-19 dashboard. And so our lab has been called upon by the community to generate a variety of data products which shed more light on where and how the NHPI community stands in the pandemic. And so this is one example of a data report that was developed for the community members, which provides a comprehensive overview of national level COVID-19 data, highlighting the impact of COVID-19 on NHPIs in areas where the disaggregated data is available. And so based on the requests that we get, we also create county level specific data reports if that's something that folks are interested in. All right, so our NHPI COVID-19 dashboard. And I'll be sure to share the link for everyone who is interested in checking this out during a later time. So once we were able to automate our data scraping, we created an online dashboard to help not only the community, but other policy stakeholders visualize the data that accurately reflects the communities that they serve. And so states that disaggregate NHPI COVID cases are shaded from light to dark brown, representing lower to higher NHPI case rates. And the states that do not currently disaggregate it are shaded in gray. And so when you're on the website and you're checking out the dashboard, if you hover over a specific state that disaggregates NHPIs, a mini line graph will pop up which compares case rates. And then if you go ahead and hover over a state that does not disaggregate, a mini window will pop up and mention whether NHPIs are combined with Asian, other, or if states do not provide any NHPI data at all. And we also have a similar window like this, but it's focused on just COVID-19 death-related data. And so moving on, the last page of our dashboard features a state-level data summary, which was designed intentionally with the NHPI community in mind. And so when you use the drop menu on the top left, you can select a specific state to learn more about their available NHPI COVID-19 data. On this slide, you can see from the state of California that provides a breakdown of racial and ethnic case and death rates per 100,000, number of cases and deaths. And also just want to note that the case rate for Pacific Islanders in the state of California is 44% higher than the statewide rate. And then on the left side, we feature some bar charts that allow you to quickly compare where states stand relatively to one another. And so before I wrap up today, I just want to share a few examples of how the NHPI Data Policy Lab's work has been really useful for some of our community leaders and community organizations that have been putting in endless time and effort to make on the ground change. And so a couple of groups that I wanted to highlight was specifically in the Inland Empire Pacific Islander COVID response team. They spent a lot of time dedicated to working directly with their health officials to get an understanding as to why disaggregated data for NHPIs were not prioritized when the pandemic first began. After several conversations, and once we were able to generate data reports, some of our team members were able to use that as evidence to justify why it is important to continue disaggregating this group, collecting the data, and also reporting it accurately in a timely manner. And so once we were able to do that, some of the things that resulted from this was increased visibility of disaggregated NHPI COVID-19 data, which I shared, support of existing NHPI organizations with CARES Act funding, which helped to provide more in language and culturally relevant health information and services. We were able to provide free COVID-19 testing and PPE resources. and also just led to more opportunities for cross-community collaboration with other highly impacted populations. And the last group I wanted to mention was API Forward Movement, which is a health and environmental justice organization based in Los Angeles that continues to work on a variety of health issues that are impacting Asian American and Native Hawaiian and Pacific Islander communities. More so, this group has been able to pivot and address more of the basic needs, whether it's food distributions, providing PPE, fresh produce, and other support to Asian Americans and Native Hawaiian Pacific Islander groups who have been affected by the COVID-19 impact throughout LA County. And so these are just a couple of organizations who have been doing on the ground work and contributing and also utilizing some of the data that we've been able to put together as a team and hopefully create positive change. And one other thing I wanted to mention that I'm sure Dr. Aguilar will share later is that we were able to work directly with the Chinatown Service Center to provide one of the first mobile vaccine sites for Asian Americans and Pacific Islanders. And so that was a great opportunity for us to just collaborate together and open up more convenient located sites for those who are interested in receiving the vaccine during the very early stages of the pandemic. All right, and just a couple of resources that I wanted to share with you that I mentioned before. The NHPI COVID-19 dashboard, it's hosted on the UCLA CHPR website. This is the link that you can go to if you are interested in checking it out later. I also mentioned the NHPI Pacific Islander COVID response team. They host a variety of resources, whether it's webinars. They also host the dashboard on there, and then they have a bunch of different resources that are in language and available for public use if that's something that you are interested in looking into. And lastly, there's the NHPI COVID-19 toolkit that was put together with the Los Angeles County Department of Public Health and other NHPI serving organizations to create more in language and culturally relevant materials focused primarily on the COVID-19 that were translated by our community and also for our community. And with that, I just want to thank the NHPI data policy team, Dr. Nunez Ponce, and all of the supporters who have pitched in to really make this a very wonderful project. As always, if you do have questions, I have left my email here for you to reach out to me, and I'm more than happy to assist when I can. Thank you.
Dr. Aguilar?
Okay, I was giving a little time in case there were some specific questions. Karina, that was excellent presentation. Thank you for the tremendous work that the UCLA Data Center does. As you mentioned, we have collaborated with you, with Dr. Nunez, and tremendous work, definitely tremendous work that has eliminated a lot of what we do. As a medical doctor and as an ally, as it was mentioned before, I work at Chinatown Service Center. 60%, 65% of our patients are Chinese, mostly immigrants. And as a Latino, I feel as an ally of the community, also as an immigrant. I share, their struggles and many times their needs. So it's been very rewarding to work there. And as it was mentioned, we do have other communities. About 25% of our patients are Latinos, and about another 10% or so are either African Americans. So quite a variety in our clinic. But to tell you a little bit about my experience is that our communities have been heavily impacted by this pandemic. Of course, healthcare has been a tremendous problem. And I'm gonna share some data for you. So let me share my screen. Okay, so let me go there. So here we go. Share my screen. Okay, are you able to see my screen? Martha?
Yes,
Okay,
yes.
I just sometimes.
Right. That's
Okay,
great. That's
so
great.
here's the data just to illustrate what I'm going to tell you. Some of the data in California, we had 69,000 deaths as of the 10 of this month. In LA County, 26,000 deaths. And then I want to give you the exact numbers that we have so far. I mean, excuse me, not the exact number, because sometimes death might be related to COVID and is not counted as such. But these are the numbers that the LA County Health Department gives us. 13,200 Latinos, about 2,200 African Americans, 3,300 Asians, and 5,800 whites. The COVID case rates, this refers to per every 100,000 people in the county, we get about 150 cases. And then very similar for, or actually the same for African Americans. I don't have a number for Asians, but for whites, it's for every 100,000, we get 100 cases. And I want to emphasize also the vaccination rates. Among Latinos, the persons who have received at least one it's 75%. I'm sorry, those numbers are turned. And the African Americans are 69%. For Asians, is 90%, at least one dose. And for whites, 76%. And you may ask, okay, doctor, I can see that whites and Latinos are very close. So why the much larger case rates? Why is it? And here's where the pandemic, let me stop and I'll come back to show you some more data. But for now, I want to emphasize here's where the pandemic, even though the immunization rates are about the same, and we know that people who are immunized have very low rates of severe disease or hospitalizations. I mean, out of the 4 million people vaccinated in LA County, only about 1,300 people who were vaccinated have been hospitalized. So most people who are being hospitalized or dying is the unvaccinated. And if I'm showing you data that says that the race between Latinos and whites, it's not that different. So why the difference in rates? And this is where the racism in healthcare, the disparities, the economic impact comes into play. Because a lot of my patients, for example, never stopped working during the pandemic. Both, immigrants or, people of color, never stop working because they work in food service, food delivery, cleaning hospitals or hotels. They are in the front line of needed services. So they had to go out. They're more dependent on public transportation, bus or train. And for those reasons, the impact of the pandemic on people of color has been so much greater because also they live in housing that is crowded, less space, less open spaces. So all of those come to play and come to see why the rates are different than the ones I showed you. Now, let me not de-emphasize the fact that In our communities, we also suffer of misinformation and the weight of, I have patients who tell me, oh, doctor, I don't want to get the COVID vaccine because I'm afraid of the side effects or what's going to happen. And I always remind them that COVID is much worse of any side effects. But there's a lot of misinformation in our communities. The lowest immunization rates in LA County is among African American and Latino youth. So young people in our communities have felt, a lot of times felt that even if they get it, the consequences will be minimal. And as you know, that is not the case. I am going to show you a few other data to see if I can convince you that vaccinations are really important. You know, very, very important. So let me go back to my screen here. And then I'm going to show you this data that shows the, as of from December through June of this year, the number of cases among vaccinated people was 0.04, and the number of cases of people who were unvaccinated was over 400,000. And the hospitalizations, 98% of those were on people who were vaccinated. And the death also, as of June, 99.8%. So as it says, 99% of COVID death in LA County has been among unvaccinated people. And also those hospitalized and the LA County Hospital are folks who were not fully vaccinated. And I want to show you one more slide that illustrates the full number of people who have vaccinated. This is as of July of this year. And I mentioned a bigger number, but this relates to July, in which there are 4.6 million people vaccinated. Out of those, 2,800 tested positive, 195 hospitalized, 21 die. And usually the people that die are people elderly or have multiple other medical problems. So fully vaccinated people, 0.06 may test positive for the virus. And about vaccines, this is regarding the Delta, Alpha, Gamma, and other variants. And this shows you how effective the vaccine is. It's about the same across all the variants, right? About 11, 9, 11% or so people may have breakthrough infections with those variants. So let me stop. And again, I want to emphasize how the pandemic and the lack of access to healthcare, because we're talking about vaccines and how vaccines may not be available in a lot of the communities. One of the things that most we remember is that in the beginning, the way that people got vaccinated was by registering on a website called MyVax. And as you know, a lot of people and communities of color, specifically older, have no access to the internet or computers. And that's where we come in. I work at a community clinic, and our job is to reach to those and their language of preference and in a way that it is acceptable culturally, in a way that it is in their communities. And efforts like ours, we need to multiply all over the country. As it was said, that's the only way we are ever going to get out of this pandemic. So with that, let me stop now, and I leave that for any other questions that you may have.
Thank you, Dr. Aguilar. I think we're open now for questions. if people would like to write their questions in the Q&A. And also we will begin with a few questions that were created among the Civil Discourse and Social Change team. So with that, I want to thank both of our speakers for this excellent presentation and to filling us in on very important details of what's taking place with the COVID among our vulnerable communities. So Clem, would you like to begin?
Okay. So this question is actually for both our speakers. I think that a number of our students in the audience today are wondering about the paths that each of you have taken, to your careers in public health as healthcare professionals. And I was wondering if you could share a little bit more what that path was. How did you become, health professionals?
I can go ahead and start us off. Definitely wasn't a linear path. Full disclosure, I was on the track to be pre-med during my undergraduate at the Claremont colleges and decided to take a year off after I graduated to really work in communities and serve and understand what health disparities really look like. During my time at the Claremonts, I was very fortunate to study abroad in the South Pacific where my family is from. And that's where I really got to learn about health disparities, health equity, non-communicable diseases, and see other healthcare related positions that are open to looking at health from a different perspective. And during that time, I went to pursue my Master's of Public Health at Cal State Fullerton, was able to really dive in and work on qualitative research regarding palliative care, end-of-life care, how we continue to approach the end of life and really care for our elders. That's something really big in my community. We hold our elders, our grandparents to the highest regard, and being able to care for them throughout the last of their days is something that we really, that is really well respected. So I was interested in looking at that during my time as a graduate student. And then the pandemic happened. I was working with a nonprofit, as mentioned before, called Asian Pacific Islander Forward Movement in LA. And I was able to really see on the ground change. There's so many moving pieces in the healthcare system that we don't get to see on the day-to-day basis. But once you're able to be in the field, talk to some of those folks who are encountering some issues, they want access to resources that Dr. Aguilar mentioned. That's where you really get to see how healthcare impacts those who have access to it, who don't have access to it. And that's when I realized I really want to be able to contribute back to my community, who is underserved, unfortunately, but by being able to create data infrastructures and build models that we can utilize to protect our families and hopefully prevent the furthering of these diseases that we continue to see. Hopefully I'll be able to gain some of those technical skills to be able to elevate my community and also others who are interested in working towards health equity.
Great, thank you. Well, my route to becoming a medical doctor started probably when I was a little one, a teenager actually. My parents and I moved from Honduras, and as usually happened with young people, was able to learn English fairly rapidly. However, my parents did not. And I remember going to a county clinic here in LA and serving as the translator for my mom. And I remember that the doctor came in and I was starting to ask me all these questions to ask my mom. And some of them were very private. I mean, what kind of birth control did she use? How many kids has she had? Did she ever had any miscarriages? And I was like, how am I gonna ask these questions to my mother? Right? How am I going to but my mom was braver than I was. And I'm sorry that I am tearing up because she already passed. And so we made it through. We answered the questions. But experiences like that many immigrants have moved me to do something about it, to get involved. In college, I was with Chicanos for Creative Medicine, which is CCM, is one of the several ethnic pre-med societies and colleges. That even helped me crystallize a lot of my ideas and the way I was feeling. And eventually going to medical school, which was, of course, as you know, is a tough road, both in and out. And then as a resident, when I applied for residency in family medicine, I only applied to county hospitals. So I worked at public hospitals is what I wanted to dedicate my life to, helping people like myself. Most of my patients are either in Medi-Cal or Medicare, and a lot of them are medically indigent. So if anything, programs like the one directed by Dr. Lopez Garza, Dr. Lai, for students who have interest in the health field, the information that you're getting should help you decolonize your mind and help you become in the future better providers, either in public health like Karina or in medicine like me, because we understand the struggles of our communities and we're able to be more effective by doing that.
Wow, thank you. Very powerful answers. And I have another question for both of you. Can you both address what vulnerability to a disease like COVID-19 means to you? Next, so this is a three-part question. Next, address what factors are contributing to COVID vulnerability in the communities that you are working with. And thirdly, what are a few things that each audience member can do now to help address this vulnerability?
Okay, I'm gonna let Karina answer first.
If you can remember them all.
That is a fully loaded question, so
It
please
is.
chime in if I do miss out on anything, but thank you for the question. Some of the vulnerabilities to the disease, as I mentioned before in my presentation, unfortunately, a lot of our Native Hawaiians and Pacific Islander families, they do live in multi-generational households. We do see that high rates of poverty are linked to a lot of the different diseases that we talk about on the daily that we're trying to address. Some of the more basic things, misinformation. With the outreach that we're conducting with our community-based organizations, we continue to see that as a huge challenge on the daily. Whether it's hearing something from Facebook that went out from a mistrusted source, or hearing something that was shared in a church youth group, because that's where a lot of our families gather. Those types of negative narratives continue to persist, and they really backtrack us when we're trying to make progress in whether we're trying to get people to access COVID testing. And then the vaccines came into play earlier this year. And we were doing really well in the beginning, working with the Chinatown Service Center, other API orgs in the area, whether it was trying to persuade health officials why it's important to bring mobile vaccine sites directly to the neighborhoods where our people can access them. Transportation is a big issue. A lot of people don't have access to cars, or they're not comfortable hopping into an Uber to get from A to B. So transportation was definitely another issue that we've had to work through. However, there are services that have provided that access, but still a lot of members are hesitant to take that just because of safety reasons. And just being able to provide interpreters and translators has been a very costly thing, especially when our budgets do not allow for it. So leveraging those types of resources has been really important for us to be able to break down some of those barriers for our community members who are interested in a lot of the resources we have to provide. The last question was asking,
What are the few things that each audience member can do now to help address this vulnerability?
at least from my perspective, I think it's pretty simple. It's learning how to be mindful of others and how to think beyond just yourself. I think there's a lot of conflict between people who think wearing a mask is, infringing on your rights, but more so, at least from how we view it, is it's being mindful of your family members who may be immunocompromised. It's being mindful of those who may not be able to access the vaccine right now to protect themselves. So just going beyond your usual self and being able to think of others when you are out in the public, going about your daily interactions is really something that I advise people to just pour more time and energy into would really make things a little bit better.
Thank you. Dr. Aguilar, would you like me to ask
Oh.
the questions again, or do you?
Well, the vulnerabilities. What makes our communities vulnerable? One is their economic status. I mean, there are folks who have to go out and work every day. They cannot stay home and do meetings by Zoom. They have to go out and work and put themselves at risk of getting COVID. So that is a reality that most of my patients have to deal with. They have to go out and do that. Now, of course, racism and healthcare, which is well noted, well documented. There's quite a bit of literature on that. Just the lack of, starting by the lack of access, having been able to go to a clinic, being able to have access in a language of your preference, in a cultural appropriate setting. Those are things that a lot of us take for granted, but it is not so for many of the people that I serve. And therefore that creates a great vulnerability. I show you data that even though the vaccination rates among whites and people of color are not that different, their case rates are, a third lower than us. And it has to do with those vulnerabilities that I mentioned to you. It has to do that folks don't have access. So, and I don't want to just tell you that it's because a lot of people don't want to get vaccinated. They just don't have the ability to be vaccinated. Now, of course, as I mentioned, there are people who have the beliefs that the vaccines are bad or they're mistrustful. Let me put it that way. Through many years of racism and healthcare, I totally experienced on my mom and being humiliated by her own son asking questions that were inappropriate, at least in our culture. And she moved forward and she said, okay, this is how we deal with this. And a lot of our women in our communities are strong and they know how to battle for the health of their kids and themselves. But a lot of people don't have that. Let me know, a lot of other folks, when they are faced with situations like that, they retreat, they move away, they distrust healthcare and they're not involved anymore. So those are things that you asked your last question, what can we do? If you're in the process or your path is to become a healthcare provider, have this to heart. Because by providing healthcare that it is appropriate, that is not racist or sexist or homophobic, we provide care and decrease those vulnerabilities. The other thing that I want to emphasize to everybody in this call, in the Zoom, at this webinar, is get vaccinated, please. I know that vaccines, you get pinched, there's a little bit of pain, maybe discomfort with the vaccine, but at the end, you're doing a service to you and to your community. And of course, if you have family members that are not vaccinated, be kind to them and, treat them with respect and provide them with the information that they need. So that will be the way that I think that we can reduce vulnerabilities.
Thank you.
Thank you very much. So let's see, our third question is for both speakers, and you've already touched on this, but the question is, what role or roles can community-based outreach or community-based care play in addressing this pandemic? What unique ways have you or the organization that you work with innovated care outreach for your specific communities? So I was thinking here when I wrote this question about telehealth, but I mean, for Karina, just getting the data, I mean, it's not available in many states for Pacific Islanders. I mean, that was a struggle.
Yes, in terms of the data, that was definitely one of the biggest challenges. Identifying where some of these hotspots was a big wall we had to jump over countless times, but we were able to kind of split up, see where our connections were, who were the biggest allies that we could lean on in these respective states who have dense populations of NHPIs, and then kind of send each other out, of course, virtually, to try and consult with the stakeholders and help us understand why maybe this isn't seen as a priority for them. Of course, looking at funding opportunities and why we are not necessarily included in that all the time, and really just pushing the same narrative that a lot of organizers who came before me have continued to share with groups about who NHPRs are, why are we important, what do we contribute to this country, and why we do deserve to have access to these healthcare resources and services. And so unfortunately, we have to continue to bring up the same conversations that have been in the works from decades upon decades. But thankfully, I think we've done a pretty good job at making ourselves present and justifying why the Data Policy Lab serves as a valuable resource to continue to collect COVID-19 data. I will share that we are looking to expand beyond the data we are currently collecting right now, looking at social determinants of health. Also want to note that the California Health Interview Survey is also housed at the UCLA CHPR. So we are very fortunate to work in this academic community partnership to leverage these resources and really pinpoint areas of need for not only our group, but other underserved communities. Just to switch gears a little bit and talk about, I know there was a question that popped up in the chat about mobile vaccine sites, outreach, what that looks like. It is a very complex logistics and coordinating type of deal, right? So when the pandemic first started, just thinking about vaccine testing, trying to get people to come out to get the nasal swab, all of the videos that were a little traumatizing for those. It was tough. However, because there was no way to identify where these hotspots were, thankfully, LA County Department of Public Health, they created a visual map or a tracker that you can utilize to visualize where specifically people were catching the COVID-19. They provided zip code data, COVID rates. So that's what we use as a tool to determine where we should be moving into, which cities have the most cases, and if we should be hosting at like a church site, at a park, making sure that it's in a space that is safe enough to maintain the 6 feet, depending on what the public health orders were at the time. They also mentioned making sure that communities were aware of the service, right? It's important to offer it, but if no one knows it's available, then it defeats the purpose. And so one thing we always like to do is consult with other community-based organizations, churches that are in the area who may be doing something like that, and just kind of work together. So we're not really reinventing the wheel. we're just leveraging resources whether it's providing the food to incentivize more people to come, or it's bringing the vaccines from the Department of Public Health. So everyone really collaborates. I think all community organizations have done a really good job at connecting with one another, since there's just so much need out right now regarding testing and vaccines. And Dr. Aguilar touched upon this earlier about making sure we have in-language materials and providing the interpreters there during the day of for events. And of course, there are always issues that come up with logistics and coordinating and making sure the medical teams are there to provide aftercare, and just making sure that all of our clients that do come in have all the information they need, not only for themselves, but also for family members who may be interested in taking that leap of faith and getting the vaccine.
In our, as it was mentioned, in our experience, we have collaborated, of course, with UCLA or the UCLA Center to provide vaccines. We actually have two mobile vans that go out to community groups, churches, parks. We go to multitude of places to both test and vaccinate people, to provide that access that is both linguistically and culturally appropriate to our communities. Because if we wait for people to show up and get a vaccine, sometimes it makes a greater barrier. The other thing that you may have heard from my bio, it was how back in March of 2020, when we went to lockdown, we have to convert our medical visits into telehealth visits. We had never done telehealth before that time. And now, in a matter of weeks, 80% of our medical visits were either by telephone or video, depending on the preference of our patients. And we were able to provide that, and we continue to do. Now, of course, it's come down because a lot of people feel more confident going out to see the doctor. They're vaccinated. As you may know, also all healthcare providers in the state of California must be vaccinated as of September the 30th. So that was something that the governor passed. And so now we're down to about 38%, 38% of our visits, but it continues to be a way to increase access. Sometimes when I call patients, they might be taking a break from work. They might be taking care of their kids while they're on the phone with me. Of course, we cannot do everything, but over the phone, but we do a lot of the important stuff. So those are some of the ways that we're trying to expand care and provide more access, specifically in times of the pandemic.
Thank you both. I think the next question, and a couple of our audiences are asking about how do you talk someone who is distrustful to taking the vaccine, and we'll get to that question as well. We do only have about 13 minutes left. But let me ask the next question that we wrote here. And this question is for Karina. CSUN, like many institutions, does not take into consideration the needs of its Pacific Islander students, which notably has been declining in numbers for the last 8 years. Arguably, this institution knows very little about this community. Could you address why it is critical for institutions like CSUN to pay attention to and devote resources to Pacific Islander students and their communities?
Sure, thank you for the question. I just want to add that I think there is so much value that Native Hawaiians and Pacific Islander students bring to the table when it comes to thinking about the types of environments that they're brought in, the culture, the very service-oriented characteristics that we provide, and just mentioning that service is really ingrained in our lives, and that's something that we always keep dear to us when it comes to trying to look towards what it is exactly that we want to accomplish in our professional lives, whether it's academically or sometimes in the workforce. And I think oftentimes, because the data does not provide the evidence that NHPIs do hold those educational values, I think it's important just to note that there is so much that these students bring to the table, and just being able to provide, better access for us to look into different areas and different fields that we're interested in can really change how some of the conditions that they're brought in. And so just thinking about why that's important and why we can tap into that. Like, for example, in the San Francisco area, they recently incorporated a Pacific Islander studies-based curriculum to really bring awareness as to who these people are, what they contribute, what we can learn from them. And I know at other institutions, the student groups are pushing for something like that, so that we're able to learn that there is representation of Native Hawaiians and Pacific Islanders, maybe not all at one institution, but we are present and we do make a difference when it comes to just studying within our respective fields. And we are interested in being able to attain those skills that are afforded to us to hopefully give back to our communities. And so I think if institutions like CSUN, like UCLA, like all of these other well-known places are able to invest and really break down some of those barriers that we may have to accessing education, there's a lot of potential growth that we can see, not only within the students, but also the generations that come after them. So hopefully this will only be the very beginning of conversations. I know that there's a lot of advocacy happening within the NHPI student groups that happen across the different campuses in the States, who continue to just make their name known on campus, whether it's one Pacific Islander or it's 10 of them. They all stick together and they definitely do their best to showcase why it's important to invest in higher education for underrepresented students.
Thank you. We've got about 9 minutes left. We should probably move on to audience Q&A. Maybe some of those questions we have not been addressed yet.
Yes, I believe Mary was going to ask those questions. Would you like to, Mary?
Yes, I'm over the audience questions right now. I believe, I know the question already had been answered about what we could do within our own communities to inform and kind of bridge the gap between the mistrust of marginalized communities and Western medicine and whatnot. But one of the questions asked by, or it was Joey Paglinian, in an attempt to reach her community, what suggestions do you have for service providers to address the medical distrust and then ultimately close the racial health disparities within the Black and Brown communities?
This is a multi-faceted approach. It has to be a multifaceted approach because the distrust of the medical community by communities of color is deep, and it goes, as many of you know, historically, and some horrible places. Issues of experimentation with African Americans at Tuskegee, the sterilization of Latino and Mexican American and other Mexican American women at a county hospital. There has been many reasons why people are distrustful. So what we try to do, and I work for a community clinic that works every day to break barriers that are either linguistic, cultural, financial, is to work to change that. to provide a different example, a different way of treating people. It will take a while. One of the things that I want to emphasize to you is that we work from a position of strength. What I mean by that is patients that are in need are doing something that is positive or good. And that's where we start. We don't start from a position of weakness. Oh, you're a bad person, or a bad patient, you're not taking your medicines, you don't go to the doctor. Okay, that's a position of weakness. Position of strength is, well, okay, Mr. Hernandez or Mrs. Chow, you're here. That's really good. That's really important. You really care. And that is a beginning of a conversation that helps people use the things that are doing to build another good, positive things they're doing to building other positive things. It never helps us to berate or blame our communities. Oh, why are you not being vaccinated? Why are you not going to the doctor? Why don't you do this? They have multiple reasons why. And by providing positive examples, positive efforts, we can start to turn that around. And of course, there's a lot more to do in medical education and college education in general. And that's the reason I'm a big fan of Dr. Lopez Garza, because the work she does, and I'm glad to meet Dr. Lai today. So you two are perfect examples of faculty who are shaping students to not repeat the mistakes of the past. Thank you.
Okay, and I have one more audience question by Moore. People who influenced you to want to learn about health, specifically COVID-19?
Well, as you know, we're in the middle of pandemic. We thought we were getting out of it 6 months ago, and then Delta came in and said, oh no, we're not done yet. COVID-19 is reshaping healthcare in the United States. It's also showing us a lot of the faults of the system, that we're great at having places like UCLA for rare diseases, but really bad about providing primary care and vaccinations. And so that's what motivates me to learn more, to do more, because the work that is needed is tremendous. As I mentioned, in California, over 64,000 people have died across the country, over 700,000. And these are somebody's father, mother, spouse, son or daughter. And those are the people that I work in every day. And that is what motivates me to do more and learn more.
Yes, definitely can attest to what was just shared. I think for me, it really comes down to the community, whether it's the NHPI community or other brothers and sisters who are really just going through it right now. We didn't expect the pandemic to last this long. However, this is something that we've just taken the responsibility of to make sure that those we are in contact with who do need access to health services or any type of resource is able to do so in a timely manner. I think more specifically of the people who have passed on from COVID-19, unfortunately for NHPIs, this was something we were hearing on a weekly basis. It was an auntie in a family from a church who passed away from COVID-19. Whether or not she had underlying conditions, we're not sure, but it's those types of stories that we hear about. It's a cousin. Unfortunately, one of our community health workers, she had to take some time off because she was doing a lot of outreach to try and get families of the church to sign up for the vaccine. And unfortunately, one of her close family members did pass away from the COVID-19, and he was of the younger age. And so it's people like that, those stories that we hear about that continue to motivate us to look into more about health research, why COVID-19 it continues to persist and how it affects our families, that really motivates me just to stick with it and just try to be flexible and adapt as best as we can, because I'm sure everyone knows how the different public health orders were changing on a daily basis, and people were getting really overwhelmed. You know, there was a lot of frustration happening, it's still happening to this day, and just continuing to be mindful and think of those who really do need the support, whether it's listening to a friend who is hesitant about vaccine data, whether it's a student who is just really overwhelmed with working a job on the side to support their family and also going to school. There's so many real life struggles that people are going through. So please don't hesitate to reach out when you can, and know that you're not alone when you're going through different challenges that may come up in your life.
Looks like there are, wait, another question came in, but I was about to say, I was actually, someone was just thanking everyone for the presentations and the work that you all are doing. So there, it looks like there are no more questions in the Q&A or in the chat box. We're at the end of time today. I urge you all to stay involved, find out about the organizations that Karina and Felix mentioned, support their efforts, amplify those voices. And, there will be more CDSC events this year. We're trying to organize an event on activism in November. Thank you very much for attending. One of my student interns will put a link to the post-event survey that we're asking you to fill out so you can evaluate our event today. And have a good afternoon. Stay safe. Be in solidarity with each other.
And thank you all for attending this event. And thank you to our great team of students, Mary, Janessa, and Vivian, as well as Clem. And thank you to our two speakers to come to the work with corazón, with heart. It makes a big difference. Thank you.
Thank you for being here and listening. Thanks again.
Really appreciate it. Thanks, everyone. Take care.
All right. Well, thank you both. That was
and
Karina, amazing work.
Yes.
Likewise. Is one of my favorite people that I go to for data.
That's amazing. You know each other.
Oh yeah, we actually spent. I went a retreat, data retreat that they have at the Arrowhead UCLA Center. So we spent a weekend talking about all of this stuff with Nines. So.
Well, we brought you together
Amazing
just serendipity. It was a serendipity, right, Clem?
Yeah.
Right, everyone? We just didn't realize, but we're so happy because it worked so well together. And
thank you so much for your time.
No,
Thank
really.
you
For your work.
All right.
Anytime you
Bye.
need us, just let me know.
Yeah,
All right.
this is definitely a contact and resources that I want to maintain. But thank you.
so we our students or whoever recorded this event. So in case either of you want to have that, keep it for your records or to show someone, we have it available.
All right. Very good. I would
Actually,
like that.
How would we get them to know that it's available? When will we send it?
Actually, to just take a step back, I think Felix, you actually started. You start recording too, right?
It must have been my computer, not
Okay, so you actually started
something
recording.
I did.
You actually started recording earlier than I did. So if you when you stop your recording, when you get the link from Zoom to.
Okay, it was. I think it's a preset in my. Hello. Uh-oh, you're stuck.
Have a recording of the program, but not of the
Okay.
intros.
Okay. It's probably a preset in my Zoom that that records automatically. It wasn't something I was doing on purpose.
Right,
but I will send it to you when I get it.
Yeah, I would like that just because I I didn't start recording the program early enough, and I also did not turn on live transcript. So I really apologize for
Okay.
that.
Very good. I'll send you what I get. Uh-oh. Computer has decided to. All right. Goodbye.